you are going to hear three people whom I respect immensely. Kimberly Moran, not only I respect her because of the work she does, but more importantly, because her daughter is studying to be a nurse. So that's that. Adrienne, I respect her not only because of what she does, but because one day in the park, she sent me a picture with my son and said, this must be your son because looks like you.
Oh.
and she has two adorable children. And Camille, the tremendous work for quite a while that is doing also. So all these three colleagues work in mental health in Ontario. And they wrote a fantastic piece for the blog that I do. It used to be every day, now it's twice a week. We're trying to detox people from the blog. I don't know if ever you ended up sending that as an op-ed piece to a newspaper, because I really think you guys should. It was a tremendous piece that I hope people read it, and if not, we can send the link, Olivia, after. And we thought that it will be very good that they share with you the challenges, and every time that there is a challenge, there is an opportunity for action, and that's what RNAO is all about. So to share the challenges and how we as a nursing community and others who are online that may not be from nursing but other disciplines and other disciplines, not bad, that you can also give a hand, because it's pretty abysmal. That's all I can say. For all people with mental health illnesses, challenges, conditions, and I want to add, and in particular for children and adolescents, I think that it's not only during COVID, let me be very clear, this is always, and I know of many, many instances where people with pretty serious issues have been sent home when probably they should not have. And people like Kim, that you hopefully will share a bit about your personal story, Kim, because I know you are open about that, of waiting for months and months and months for a child to be seen. And I know of many others. And it just is unfathomable. That's what it is in my view. So with that, I think I will leave you guys to share, and share not only the challenges, also the work you are doing, and leave us with a message of action of how do you think we can help? What do you think is the most impactful way that we can open doors to real action, or push doors, or force doors to real action, which inspire or force, depending when and where and whom. Thank you. Thank you for joining us. All yours, Kim, take it over.
All right.
Just wanted to confirm that you can see your slides okay.
I can't.
No.
No, neither can I.
Either.
Okay.
No, not yet, Susan.
How
There we
about-
go.
Yes.
Okay, good.
That is fantastic. And just so you know, 150, we passed the 150. Excellent. Excellent.
Okay. Kim, did you want us, Kim or Camille, do you want me to get started? Does that work?
Go ahead, Adrienne.
Okay, fantastic. So Doris and the RNAO, thank you so much for having us here tonight. We know that mental health and addiction and harm reduction is something that the RNAO has been ahead of for a long time. And so we're thrilled to have you as a partner in this discussion and action. And we're very happy to be here with you tonight. So we're just going to start by introducing who each of us are. We're going to assume you don't necessarily know who we are, and then we'll go and we're each going to cover a certain number of topics, and then we can engage in a dialogue if that works with the rest of the time. Okay, next slide, please. These are our three logos, so we can go to the next slide. And I'm keeping myself on mute as much as possible because it is bedtime and bath time in my house right now. And as you can see, I work from my bedroom these days, and the bathtub is right there. So bear with me, bear with me. Addictions and Mental Health Ontario is a member-based association, and we represent over 200 providers of supports and services across the full continuum of mental health and addiction and across the full lifespan. Our members are all not-for-profit or charitable organization, primarily community-based services, many of whom were established based on a need that was not being met by the traditional healthcare sector and in primary care hospitals. But we also have a handful of hospital-based services as membership, including some hospital-based withdrawal management programs, outreach programs, and the specialty psychiatric hospitals. And our main work is advocacy, government relations, policy, member communications, which just like Doris, we've just moved, RNAO, we've moved from daily bulletins on COVID to twice weekly, and we're also doing weekly webinars. So our work has really shifted in the last little while of a focus on advancing mental health and addiction to how to support our members through continuing to be able to provide services to clients living with mental illness or addiction condition. And we have a full range of services across the continuum, and our vision is the best mental health and addiction system anywhere. Next slide, please, and then over to Camille.
Thanks so much, Adrienne. And thank you, Doris, for this kind invitation. Really happy to be part of this conversation tonight. And on behalf of my family, thank you to all of you listening for your work on the front lines. Truly very grateful. So I'm CEO of the Canadian Mental Health Association here in Ontario. It is obviously a nationwide organization. CMHA is the oldest nationwide health charity in the country, so very long roots. And we obviously have a presence in every province in the country and one territory. So here in Ontario, we provide communications and policy support and government relations, very much in keeping with the work of the RNAO to our members, 28 branches across the province. We take our role in advocacy and policy development very seriously. And throughout this pandemic, we've worked on a myriad of issues, many of which are completely unrelated to mental health, unfortunately. But we had to keep the trains running on time and make sure that our branches had what they need to stay open and to continue to serve clients through what we can all agree has been a very stressful time. So we do a tremendous amount of work in mental health awareness, and we partner with Adrienne's organization and Ontario Health in quality improvement work. We run Bounce Back, which is part of Ontario's structured psychotherapy program, and the Centre for Innovation in Campus Mental Health, along with our colleagues at Colleges Ontario and the Council of Ontario Universities. And we manage a lot of the justice work as it relates to the intersection with mental health through the Human Services Justice Coordinating Committee. So that gives you a little bit of a taste of who we are and what we do. And I look forward to the conversation after our slides. So I'll now pass it to Kim.
Well, hello, everybody. And it's so nice to be included here on this panel with my friends and colleagues, and also with Doris, who has given me so much terrific advice over the last couple of years, and I so much appreciate it. So Children's Mental Health Ontario represents about 90 child and youth mental health centers across the province that deliver evidence-based, high-quality treatment to almost over 130,000 kids annually. No referral, no OHIP card necessary, and it goes from services in a walk-in style environment in many communities across the province, over 80 walk-in clinics now, all operating virtually today, but normally they're in the normal walk-in style, all the way up to the most intensive non-hospital services. So that could be 24/7 care for kids who have the most serious mental health issues. They may be a danger to themselves. You know, many of the kids who come to our services might have had child welfare experiences, those kids who have trauma and who really need mental health services. But many times it's kids who are just like yours and mine, and it was mine. And as Doris mentioned, that's why I'm very, very passionate about this, because my 11-year-old daughter became sad, and while she was waiting for help, because there are very long wait times in children's mental health services, she went from sad to depressed to suicidal in 2.5 months. And so I got to see that we just don't have the services for kids that we should have in this province. And kids like my daughter, with the right evidence-based treatment, can do well, as all of you know. And as Doris said, we're very proud. She's now just completed her 2nd year of nursing. And so kids do recover. So what CMHO does is we advocate for government investments, and we do that, of course, by developing policy. And we develop policy with organizations like RNAO and Lift from Work like ECHO, but also with our colleagues and our members, and develop recommendations for government to implement. We have been very loud advocates talking about kids waiting too long. You may have seen our hashtag Kids Can't Wait. And we've tried to make sure that politicians understand that kids shouldn't be waiting sometimes up to 2.5 years for treatment. So thank you for this opportunity, and we'll go on to the next slide.
Okay, great. You know, we really thought that it was important to ground today's discussion with starting to talk about equity in mental health, and particularly given the events that are happening right here at home, as well as in the US with the protests, because of some very devastating events, which are events that have been going on for generations. I think leaders like Kim, Camille, and I, who have the opportunity to lead discussions with groups like you, also have an obligation now to speak up a lot more about anti-Black racism, about anti-Indigenous racism, and how it connects to more detrimental impacts for outcomes related to people that are at the intersection of race and living with a mental illness or addiction condition. And there's no question that the outcomes for Black Canadians, for Indigenous Canadians, are worse when it comes to mental health and addiction than they are for the general population. I'm sorry, that was, I'm learning myself, right? I'm living speaking from a place of privilege as a white woman than the Caucasian population. And so, you know, we really think that it's important that as I talk about a vision of the best mental health and addiction system anywhere, that's the best mental health and addiction system that works for everyone anywhere. And we don't have enough services in mental health and addiction right now that serve the particular needs of the Black and Indigenous communities. And I think a big part of our work to sustain this momentum that hopefully will lead to continued improvement. I know I'm committed to being part of that change, will include organizations like AMHO, like my colleagues, really supporting Black and Indigenous-led efforts to build up services and supports that are evidence-based and meet the needs of their communities. It's also important to talk in mental health about other social determinants of health, like it is in physical health as well, and that as well as other identities. So people living with people from the LGBTQS plus community, women, people experiencing homelessness, people living in poverty, people sleeping rough, people who use drugs. These are all communities that are not receiving the same level of services as people like myself. And we've got a lot of work ahead to make sure that our services are co-designed and implemented in a way and developed in a way that meet the needs of those communities and that contribute to a goal of an anti-racist society.
Can I make a comment, Adrienne?
Sure.
Very quickly. So I absolutely agree that people that are racialized or low socioeconomic status or other types of unfortunate stigmas get less care and less access. But I go back to Kim when she met with me the first time for lunch. She's not racialized, she's not low socioeconomic status. So the situation is abysmal on top of everything for everybody. You know what I mean? Is because one can say housing, that's more to racial. Here too, I know that here too, I'm not discounting that for sure, but it's so extensive and so like it's abysmal.
Oh,
Period.
Doris,
And on top of that, more abysmal if you're racialized or if you're, yeah.
Exactly. I couldn't agree more. I mean, Doris knows, I spoke at, we have a wonderful member organization called Across Boundaries, which serves the Black community. And I spoke at their AGM, and I felt really conscious of my privilege and race doing so. And I spoke about my own dad's story. You know, he was a man who came from a middle income family that had wealth. He was a teacher, he had a job, he had a pension, he had a home that he owned, he had a family that loved him, and he ended up dying on his own as a result of schizophrenia, and was only found by police because of the smell coming from his condominium. And I think and he had before that interacted with the justice system and been put on a forum in a hospital and stayed there for 10 days and then sent back on his own with no connection to community, just a prescription for Respiridol in his hand, like everything was supposed to be better. And he was going to fill that prescription. The prescription was unfilled when I found his wallet after the police called me. And I think, oh my gosh, like he had all the privileges available to him, and that was his outcome. And so I think if we go to the next slide, this is when we talk about, and we'll talk a little bit more about sort of the impact on mental health and addictions post-COVID. But where I wanted to ground this before we even talk about the crisis is we were such a system already under strain to begin with. Kim spoke about the wait list for kids' mental health. We've got a bunch of kids' addiction programs. The wait list to access a residential addiction treatment bed for a child or youth is coming up on 2 years. That's, you know, a kid who's dealing with an addiction that might kill them if we're talking about opioids, if we're talking about alcohol mixed with something else. And many of them are dealing with suicidality as well. We have long wait lists for residential addiction treatment. We're in the middle of a very serious overdose crisis. We had tremendously long wait lists for supportive housing units, for rent supplement units, for assertive community treatment teams, all of those evidence-based measures that help keep people out of hospital. And we were seeing data after data after data come up that was showing that the number of people who are accessing mental health and addiction services for the first time in an emergency department is growing. That's exactly the opposite if you're building up a community sector. And so we were quite relieved to see that the government finally released its roadmap to wellness, a mental health and addiction strategy. You'll see it's all on public record that we were also frustrated that that strategy didn't come attached with dollars to it. We were promised those dollars were coming in the Ontario budget, and then COVID hit. And so we were very much at a crossroads of thinking that we were starting to gonna see some systemic progress in our system, and then found ourselves, as all of you do, and most of you probably are on the front line, and thank you so much for what you're doing with COVID-19. And our immediate thought was sort of thinking at this from a risk-based perspective. We've got more than 20,000 beds across the sector, and many of them are in congregate living settings. And these are living settings that are, I've got youth residential treatment that are living in really sort of camp-like facilities where they've got sort of up to 4 to 6 kids in a room together. And so while we know the disease is not, or the virus isn't showing itself isn't presenting in kids and youth in the same way it is in frail seniors, obviously, we did feel like those congregate settings were a real risk for developing COVID-19. And we saw in the developmental services sector a horrible situation where one of their organizations, unfortunately, had to completely shut down when they went into outbreak and send all of their clients over to the hospital while they sorted out their situation. And we were very, very concerned about this happening in our sector. And Doris heard all of us asking on our daily calls and our weekly collaboration calls that yes, this population is nowhere near sort of as medically compromised as the average long-term care resident is, but they are still highly vulnerable in terms of their mental well-being. These are people who are actively suicidal in a lot of cases. And on the adult addiction side, there is a lot of medical, physical compromised, very compromised immune system, liver disease, Hep C, and both on the kids and adult side, a lot of people with nowhere to go except the emergency department. Kids, as Kim said, going through the children's aid system, and on the adult side, you know, people living with either mental health or addiction issues that have really alienated their families. And so we kept saying to government, we got to pay attention to this sector and try to get PPE and testing into the sector as quickly as possible. And unfortunately, what I would report today is that we are still waiting for PPE, and we just got testing happening last week, and it seems like it's happening, but we are still waiting for PPE. You know, the other thing I think is important to note when we think about the frailty, not the frailty, but the vulnerability of the people in mental health and addiction, is that on average, people living with a mental illness or addiction live 20 years younger, or sorry, die 20 years younger than the general population. And so these are, and that's not, and you might think, oh, well, that's related to suicide, that's a problem in itself. We shouldn't, as Doris said, we shouldn't be sending people out of care before they're ready to come out of care. But it's well beyond that, because it's about complicated health conditions and complex chronic conditions. All right, next slide, please. This is my last slide, and then I'll pass it on to Camille. And so the sort of frame of our blog post that Doris was talking about was really that we felt in the response to COVID-19 that mental health and addiction was experiencing structural stigma. And a lot of Camille, Kim, and my job was focused on trying to get heard at the same level that physical health was being heard. And there's work, Dr. Thomas Unger, who's a noted psychiatrist, he's written extensively, in case anybody's sort of hesitant on whether structural stigma actually exists in mental health and addiction. Dr. Thomas Unger has written extensively that it is present within hospitals. We know that it also exists in primary care. We know it exists with police. We know that it exists in long-term care. And so what a big part of our work is bringing down that stigma, but also trying to use best practices and evidence to make sure that people who are living with a mental health and addiction condition are able to access the physical health care they need. Back to sort of up at the association level, we were really having to push and push and push to make the case that mental health is health. And this was so frustrating just weeks after the big government's roadmap to wellness came out, and politicians of all stripes at all levels of government were talking about how important it was for all of us to be taking care of our mental health care at this time. We waited, I think, a month before any of us were accepted onto the daily COVID calls or onto the collaboration table calls, despite repeated requests to all levels of government to be represented so that we could support our members to keep services open for the people that needed them. We started drafting our own guidance documents. We saw guidance documents coming out from various sectors, and we had to start drafting our own guidance documents. The Center of Excellence for Mental Health and Addiction did help us, and they should get credit for that. But then after it was finished, after a full consultation, it sat with the command table for over a month before getting disseminated. We're still waiting for a change regarding our community-based mental health and addiction guidance documents that says face cloths are acceptable for healthcare workers in community-based mental health and addiction, which makes no sense because the directive for all masking is that healthcare workers should use medical masks, not cloth masks. And then, you know, I think lastly, before I pass it over to Camille, it's important for us to say that we were very disappointed. We were very, very pleased with the announcement that pandemic pay was happening, and we're so happy that frontline heroes like all of you are going to receive that pandemic pay. That being said, we were really frustrated that social workers were not included or registered psychotherapists were not included in the pandemic pay guidelines for our sector, because really very much they're a lot of the lifeblood along with nurses in the work that our members do. All right, over to Camille.
Thanks, Adrienne. So we'll go to the next slide.
Are you not seeing it?
So yes, I've got it now. Thank you. So I'm going to carry on from where Adrienne was speaking about structural stigma, which I think is a term that Kim and Adrienne and I use to talk about how we feel oftentimes. And it's been, as has been articulated by Adrienne, it has been really evident throughout the last 3 months through this pandemic. I don't think there is any sector that feels that they couldn't make a case that they didn't get all that they wanted. I think everybody's feeling stressed and worn out from the stress of all of it, and I think with good reason. But as Doris referenced, as Kim referenced, as Adrienne referenced, many of the issues that we deal with day to day have a very long history attached to them. So we feel like we're starting far behind the starting line when we have these conversations, because we have so much room to make up in terms of where we really should be as a sector in our funding, in the way the province views us. And I don't say that as a criticism as much as it really is just a reality in terms of the level of recognition that this sector has traditionally garnered within government. I can tell you, having been around for a while and been through more than my share of elections, Election day was two years ago yesterday, and every single party talked about the importance of mental health and addictions. Every single party talked about the investment they would make in our sector. Every single party had it as a priority. It was, without question, the least partisan issue, I think we can say. I think people generally agreed that as a society we needed to step up and to start to make some headway in terms of how we saw this, how we treated our those who were struggling, but also, and perhaps more so, to get some recognition and attention on the fact that this is really ubiquitous within society. Everybody knows somebody who's struggling. Without question, we all go through difficulties in our life. So it's a day-to-day thing. This is not necessarily just talking about people who have very serious mental illness. This is talking about how we are in terms of population health as well. So with that in mind, we really have worked extremely hard. I think the three of us have really tried to decrease those barriers, to really engage with government, to try to make significant strides, and to really try to bring some of these attentions to the fore. And then along comes the pandemic. So the emergency orders are really just another good example of issues that Adrienne was talking about. You know, it was shocking to us that I recall very clearly on a Sunday, the Premier made clear that he was going to give hospitals the ability to have emergency orders that would get them the changes they needed to existing collective agreements so that staff could be moved to where they wanted to be. And whether you agree with that or not, it was really fundamentally important to our colleagues across the province in each of our organizations to have that same authority to be able to do that. And it took us, without question, at least 5.5 weeks to make that case to government. And that was every single day. And that was with the help of legal counsel. And that was with the help of all three of us talking to every person across the Center of Excellence in Addictions and Mental Health, the Ministry of Health, folks in Treasury Board, across the gamut. We really worked hard to try to convince people that this was critically important. And not because we really just wanted to have the same rights as hospitals, but because our folks on the front line were dispensing medication, they were providing food security, so truly putting their own health at risk as they continued to ensure that meals were provided to those in need in our clubhouse models and in other places throughout our organizations through that time. And also, frankly, continuing to see clients face to face, which again it was indicative of the fact that government in many respects doesn't entirely understand what we do on the ground in community, because they very clearly didn't appreciate or relate to why we would need those same powers to continue to do what we've done on a daily basis for decades. So the $6.5 million investment in emergency funding, you know, this was of course helpful. You never want to say no to money, but really falls far short of realistically what we need as a sector. I think one could argue that it is really embarrassing, I would say, for the province to give us so little money. So I believe it was Kim that did the comparison. Alberta, we all know what's going on in Alberta right now. We all know the price of oil. We know what's happening to that province. We know how much they're struggling, and yet they committed $25 million. So the equivalent amount would have been $75 million here in Ontario. So it does beg the question of how are we really prioritizing mental health and addictions? How are we really ensuring that we want to make a difference, to right some historical wrongs, and to really take care of people who without question are going to struggle with their mental health through a pandemic. Next slide, please. So our clients, our frontline workers, all of whom are at risk, we have seen what's happened. Obviously, all of us have witnessed what's happened in long-term care. We have watched our colleagues on the front line try to do their level best to continue to provide the same level of service and care that they needed to. Adrienne referenced the issues with PPE. We have really witnessed a time when supply chains that we would typically have ran dry. Priority was clearly elsewhere. Some of my colleagues were actually told, you know, you need not apply for PPE here because unless you're a hospital or long-term care. So that made their work exceptionally difficult. This is particularly true in addictions treatment facilities, some of whom are Adrienne's members, some of whom have perhaps not typically used PPE, found themselves in need of it through the pandemic. Supportive housing, I can tell you, unfortunately, we've lost a couple of clients who were in our supportive housing units. This is, again, it's difficult to tell a population how they have to behave. It's difficult to say to people who are struggling that they have to stay indoors, that they can't go out and live the life that they're used to, and find themselves outdoors and in contact with other individuals. So really, there were throughout the pandemic, a lot of difficulties that our members faced with managing this population that they typically serve. So as we move forward, we're looking at targeted funding to allow for more clinical staff. We have to really take a step back and look at our IPAC needs. We have to really start to nail down how we have a secure supply chain to PPE. Many of these protocols, again, some of the sector had used it, not all of the sector had used it. So it's kind of a new day for a lot of our colleagues, and we're moving forward to try to put supports in place for them that they perhaps had not had before. So in terms of the complexities that we know about, Adrienne referenced that lifespans are shortened. A lot of the medication that clients or patients are put on is responsible for that, as we all know. Very often there are issues of diabetes and other obesity and other issues that are clearly detrimental to one's health. And frankly, it's, you know, this is not new. This is something that we have known for a very long time. And yet, again, it speaks to the stigma of not being able to really manage that in a way that it gives people the lifespan that the rest of us enjoy. And there are many reasons for that. It's probably the subject of another webinar, but suffice to say that stigma is really, I would say, very closely related to that. So as was referenced, immune system difficulties, liver disease, again, all of this related to the meds that they're on. So we have, along with our system leaders across the province and public health, we have really tried to raise these issues. We've tried to advocate and lobby. I would really welcome partnering with you in this, because I think we have a natural connection here and wanting to see the physical health of people who have mental illness improved. And there are lots of ways that we could go about doing that. And I think joint advocacy around some of these medications that really need to be modernized in such a way that some of the side effects can be managed. And that would take investment, it would take advocacy, it would take a joining together. And I would welcome that. So perhaps that's something we could speak about, Doris. But on that note, I'm going to turn it to Kim. I think she's up next.
Thank you. And what I'm going to be talking about is what we can see going forward. So we've talked about the second wave coming of the pandemic. Well, we're going to talk about the second wave, including mental health problems, a mental health pandemic on the horizon as well. And so, of course, one of the data and the research shows from other really challenges that the world has gone through is healthcare workers' trauma really drives significant mental health issues. And I know that RNAO has been a big advocate for this as well. And I think that's really important. But the evidence has been clear that healthcare workers and their families need support, not just now, but over the long term, because of the trauma associated with caring for all of these very ill people and in some of the very difficult situations they're in is really a driver for mental health issues. And I'm going to, as you know, the work I do is around children, and you have to think about the impact of parents going through trauma on their kids and the mental health issues that come from that as well. So it's really around making sure that families are healthy. We also know the data is already showing us there's a problematic rise in substance use. And, you know, I think that, you know, we've seen rising rates of purchases from the LCBO. Several studies have shown that there's going to be, that there's increased usage, and often increased usage then ends up with substance abuse issues. And for those who are struggling with substance abuse already, it's an increase that they just, you know, is not helpful to them. The stress on families from economic shutdown and isolation is something we've really never seen to this scale before. So what's happening to our families, and what are the mental health issues that are going to come from that when families are stressed? And what happens to their kids? We know that the social determinants of health, and RNAO has been big leaders in this issue for sure. The impact is going to be even more extreme for those who have low income, who are precariously housed, and as we've already talked about, pardon me, racialized, and First Nations, Indigenous Ontarians. We know that those groups were served very poorly prior to the pandemic, and we know the pandemic will have a disproportionate impact on them, and that we need to pay a whole lot of attention here. Can we go to the next slide? So we also know that kids are struggling. We have never had a situation before, ever, that we can think of, perhaps in wartime, where we had so many losses for children. And we don't know the impact on their mental health. The loss of school supports and structure is immensely important. Now, I will say, for some kids who have anxiety, and school is a big driver for the anxiety through social or performance anxiety, sometimes they're doing a bit better right now. But you know what we worry about now is what happens when they go back to school and they haven't been in that situation for 6 months. Dynamite. And for those kids who have aggressive issues, perhaps towards their family, you know, home is a really difficult place. And I talk to too many parents who are struggling with kids who might have comorbidity with ASD, and their kids are really struggling, and the families themselves are struggling, and we don't have enough respite in the province for those kids. We know that figures are showing in Italy and others who have gone before us, increased domestic violence and abuse. That are all signs of stress in our families. And when children witness this, they can't help but be traumatized. And so many of the kids in the children's mental health system have suffered trauma through child welfare involvement in their young lives. The missed developmental stages. We don't know what's going to happen. Schools provide that sort of a way that kids meet the next levels of development, and we're missing those. The loss of play, that is critical to development. And of course, the lower physical activity and increased screen time. We don't know what the impact of this is, but all of these are drivers to much more poor mental health. Next slide. So we're already seeing data that is really concerning to us. You know, our crisis lines are starting to go up quite significantly. We know that for kids health phone, a 350% increase. That is enormous amounts. And we know that those kids, we know from a population health approach, a portion of those kids are going to have serious, long-lasting mental health issues that are going to require treatment. And they're going to require treatment in a system that was already overtaxed, where treatment times could have been up to 2.5 years, if you can believe, particularly for kids who have more serious issues. It doesn't make a lot of sense, of course. In other parts of healthcare, you would treat those kids with the most serious issues first. But in mental health, often it goes in reverse. There was a 90% increase in mental health related calls in Toronto over the May long weekend. And that really shows where families are struggling. We don't know how this is going to work for families. We know there's resilience in people that we are tapping now. We know that people and families have fared through very complex issues, but we also know that there's going to be a percentage of families that really aren't going to do very well in this pandemic and after the pandemic. And community mental health agencies across the lifespan are there to help families, to help children, to help adults, from those with mild mental health issues to those who have the most serious, complex, and long-lasting issues. But we weren't faring well before the pandemic, as you know. The expansion of services was important then, and it is going to be more important after the pandemic. So you asked Doris what we can do and how you can help. So government has to act. We need to address long wait times. Kids can't wait for 2.5 years. That's just simply ridiculous. People waiting for addiction treatment programs, when the window opens and they want to get help, they need to get help right now. Government must take action so that we can ensure that there's mental health services when and where families need it across Ontario. And we need to build services because we know volumes are going to go up. So what do we need you to do? Join us in our advocacy. All of us have been advocating to government to say that mental health, expansion of mental health services, mental health and addiction services must start now. We can't be behind the 8 ball like we have been in long-term care, like we have been in many other places during the COVID crisis. We are waving the flag now, And we need all of you to help us make sure that the government moves on this and doesn't wait until we're all saying, oh, look it, we've got a problem. We want to start now. So please, please join us in our advocacy. Next slide. All right, thank you, everybody. Thank you so much for listening to us.
A quick question, if you don't mind. Can you comment on your link with the Center of Excellence, the famous Center of Excellence that the government announced, just to know how are you connected, what's happening with it during this time? It's 5 months, right? How are you linked to it? What are the priorities?
Well, I think that, do you want me to give a crack at it, ladies? I think what we know now is that Center of Excellence was just starting to get going. Center of Excellence in Mental Health and Addictions was starting to get going when the COVID crisis hit. So their job is to implement the Roadmap to Wellness, the government's plan. And so they were just at the very beginning stages. They didn't even have staff, for God's sakes, and the COVID crisis hit. And so right now they're trying to get up a very big learning curve. We had staff of theirs on our member call today who said, we don't know anything about the child and youth mental health system. We're just learning. And they're very honest about that, but there is an enormous learning curve to go. And I would say that there's some very dedicated people who will come to the file, but it's all happening in real time. And I would say, just like everything else in healthcare, everybody's very COVID focused, which is necessary, but we need people to step back and look up and say, there's a new pandemic coming. And so what we need is for the government to take a look at that. We are working
and as you tag along also with the other colleagues, comment also on Devlin's table that you were part of. Where did that end and what happened with that and what came out of it? Because we all send submissions everywhere.
Yes, I was very, I would say, happy to be part of the Premier's Council for Healthcare. At this point, as I understand, it's on hiatus because, you know, it was during the COVID crisis, it made no sense to gather people together either virtually.
Yeah, but this was a year before the crisis, with all due respect.
Oh, absolutely. So the recommendations that were made, I think, are solid. The government hasn't implemented those recommendations. Part of the recommendations were a big expansion of mental health services, and we didn't see that happen. So the government has been very slow on the uptake of those recommendations, sadly.
Hey, Doris, can I go back? Sorry. Go ahead, Doris.
For all of you, if you are hopeful.
Yes, so that's what I was going to say. I want to go back, take one quick step back to the Center of Excellence, if I could, because I want to sound an optimistic note on this. I want to echo what Kim said about timing is everything in life, and unfortunately, their timing was bad because we were walking into a pandemic as they were you know, getting their desks in place. Where I'm optimistic, though, is if you think about Ontario Health as we understand it now, and you think about the Center of Excellence for Mental Health and Addictions being part of that, we're the only sector that actually is pulled out and has a dedicated staff and a mandate and really the kind of recognition that I think for a very long time many of us have been talking about what's needed. And you can go back 10 years to the Select Committee, which I think was really the place in which Minister Elliott was really reaching back to when she was thinking about a Center of Excellence. We don't know where the future of it is. Adrienne expressed concern about the strategy not being quite where we wanted it to be. And that's all certainly true, but I have to believe that the Board of Ontario Health, if they truly want to make a mark, is going to look at mental health and say, we could really move this forward. We could
do they
really
want to make a mark?
I'm told they do. I've been told that by many people who absolutely know.
If you're told, I'm told that long-term care will be fixed, and I have been told by 3 or 4 premiers.
Yeah, I hear you.
5 ministers, with all due respect to Adrienne, George cried and told me he will revolutionize long-term care, and nothing ever has happened. So I don't believe anything until it's happening. So
I hear you.
I want to know if you are more hopeful, and if yes, why?
I am more hopeful with the center in place. I am hopeful because I just fundamentally think that that this government is going to have a hard time in 2 years convincing Ontarians that they took mental health and addiction seriously, that they have something to say in their platform, that they can point to having made significant investments. They cannot make that case right now. We could give them chapter and verse of where they've fallen short. So I think they have put this bright, shiny object called a Center of Excellence in the window, and it's up to all of us to say, now it needs to deliver. So we're prepared to give them a little bit of bandwidth because we've all been through a pandemic and we get the timing, but moving forward, that has to mean something. It has to mean something for all of us, most particularly, I would hope, the Board of Ontario Health, the Premier's Office, the Minister of Health, all the rest of us. We have an opportunity here. That's why I'm optimistic.
And I think that's entirely fair. And I think that's actually where all of the RNAO can be very helpful, right?
I agree.
The RNAO, so Kim, you said that I gave you very good advice in the last 2 years, and I appreciate that. RNAO will be on your side if the three of you, the same that now you're being vocal, if you don't see outcomes in September, October, that you organize and we will help you organize. I have lived already 20 years of political parties and ministers, not just this government, it's any government, all the way back to Bob Ray. And the reality is, as sad as it sounds, and Eric Hoskins was the first one the only one that honestly answered that to me when I went to screaming with patients that had amputations because we didn't cover for offloading devices, $1,200, but yes, for an amputation, $70,000. And I said, how is it possible? Why do we need to bring people with amputations to the legislature? And he was the only one so far that has answered honest. He said, Doris, as a minister, I don't even know everything that is covered. There are so many things in government that unless people scream like you are doing now, sometimes we as ministers don't know. Now, mental health is more difficult to not know, but I do think you will need to put a tremendous amount of pressure after the mess on long-term care gets fixed. I don't think you will get lots of attention before, but you should be next online, develop a whole strategy, and we will be there right with you. From children to older persons with mental health, in home, in community settings, in congregate settings, wherever. It's the whole thing. And you're right, Camille. There is now at least a center that should be able to pull it together. And a minister, Christine Elliott, that is interested very much. So
No question.
No question.
So is
No
Tivolo.
question.
And
You
so
cannot.
is Tivolo. But you guys need to organize like never before together, and we will be with you.
And you know what has made me the most optimistic is you think about the importance of the work of the Center of Excellence. And I was really publicly supportive of the Center of Excellence because I think there is a lot of work that needs to be done around making sure that across each part of the province for each population that we have the right basket of services and that those services are delivering against the best evidence. And we know we've got too much standardization and variation, and we also know that there's a lot of services that need to be funded at a higher level to deliver against that best evidence. What makes me feel the most optimistic right now is how tremendously resilient and innovative and tenacious our frontline providers have been. Over 90% of our members have stayed open, of all of our collective members have stayed open over the course of this pandemic, have not closed their doors, have served their clients. And that is what gets me up in the morning. That's what gets me the most excited right now.
Yeah, and I have to tell you a story. I'm so glad you said that, Adrienne. I have to tell you a story that I referenced when I was in my slides about the Premier announcing emergency orders. And on that Sunday, there was a lot of debate about who would be allowed to stay open. So what was that going to look like? So we're shutting the economy down. How are we going to figure out what this looks like? And my email started to go bananas. My phone was ringing off the hook. And it was all of my colleagues across Ontario saying there will be civil disobedience in the streets if they even think about shutting us down. We will serve our clients. We are staying open. And, you know, I got a relatively mild-mannered group. You know, they're really genuinely polite, law-abiding citizens. And I thought, holy, you know what? I'm going to go from mental health to, you know, paying bail to get people out of jail because they're just going to go bananas if the province tries to shut them down. And I think I wrote an email that night to my family saying, I've been proud to work in this sector, no more so than today.
Beautiful.
May I interject at this point, just because I wanted to take a stab at summarizing a bit of what's in the chat box and also bring forth a few questions. First of all, I just wanted to let you know that there's a lot of gratitude in the, from people in the chat box saying that they're thanking you for your dedication, your determination, your passion, your information. Some affirmations for sure that this is a problem that needs to be addressed. And Angela spoke about a lack of changes from her work in 1985, that really nothing has changed in children.
And Angela is my president.
And then there are some great comments from Liz and Louise and Kathleen. So you might want to take a look at those as well. So questions. The first question is from Shannon, and she's saying, what service barriers and deficits do you find prevalent in rural versus urban?
Oh,
Any way specifically that you feel we could service more mental health and addictions concerns in rural areas?
well, I'll just start, if I could, ladies, and just say the one I'm hearing about, particularly through the pandemic, is internet connectivity and the inability to do virtual care because of the infrastructure that is non-existent and or spotty at best, is maybe how I'll put it. So that is very concerning, because I think there's an automatic assumption that many of our services can just convert to a virtual platform because that has worked in some parts of the province. It just doesn't work everywhere. So I'll use that as an example.
That's a very good point, though, because that also tackles mental health, that also tackles primary care, period.
Oh, absolutely.
So
it's
big.
very, very worrisome.
Educational resources and everything else.
Yeah, and not only that, it's the cost. I mean, we're talking about people who, you know, they don't have cell phones. If they do, they're not inclined to use their data to access service. And, you know, I hear this very directly from my members who say, this is just the reality that we live with. It's not something we can undertake.
I'd add that we also know that stigma can also be much higher still in rural communities, particularly I think of farming communities, and even more heavily so on the addiction side. And so people are really, there's an additional burden to come forward and ask for help. There may not be services as locally in the community, and so being able to stay employed while seeking services. Your only choice to get services might be to travel out of town to a residential addiction treatment organization rather than access through something closer to home. And so I'd say stigma, and, you know, what can be done there for all of you on the line. I think the more we talk about it, the more we ask, how's your mental well-being? How's your substance use? You know, are you doing more online gaming? The more we're asking people, that's breaking down stigma.
Yeah, and I would say for kids, I mean, I think the biggest problems have been is access to services. You know, there isn't buses often. There isn't public transit they can rely on. Sometimes they don't want to tell their parents because family and home may not be a safe place for them. And so they want some privacy when they're accessing services. And so, you know, our workers go where kids are. So that could be in a park. It could be, you know, at a community center. It could be near their school. But that often is an issue because privacy in your home, even now it's a big issue for kids. If they're trying to get virtual care, you know, how do you have privacy? And there's been some super unique stuff going on where the therapist gives the kids some, you know, those big headphones, and then the kids might type or text their reply to the therapist so that they have some privacy. So there's some very unique and innovative service models, but you know, it is more challenging for sure.
Thank you. Can I ask another question as well? About domestic violence during the pandemic. Can any of you speak to that? That's a question for Marianne.
Well, we know, I'm going to be honest, I don't have the figures at my fingertips. We know that the incidence of domestic violence has increased really quite dramatically through the pandemic. We have been hearing this, I've been hearing it from my colleagues. It is obviously exceptionally difficult in any circumstance, but clearly having people hold up together who, where that is a possibility, has certainly added to the numbers. My colleagues work in this area. They have certainly helped individuals who have suffered at the hands of their partner. It is truly frightening. I think we can all agree. I wish I could offer more on this. Suffice to say that it is data we haven't collected per se. I think we could have a whole conversation about data collection and the stigma associated with our inability to collect the kind of data we need. But again, that might be a different webinar for a different day. I'm glad you raised it. It is very much on our conscience. I sent a note to my colleagues just last week on the subject, and like you, we are watching it quite intently.
And I will say the data from Italy showed a very significant increase in violence against women and child welfare cases post-pandemic, or as they came out of the big increase. So I would expect that we'll see data coming from the specific service agencies fairly soon, showing an increase as well.
And the data from Connects Ontario, that is a provincial mental health and addiction resource, shows that there's been more calls for domestic violence support, as well as support for people who have been the perpetrator of domestic violence, looking for mental health and addiction supports for themselves, unfortunately.
A follow-up question to that. Were all the women's shelters still open, and did their clientele go down because perpetrators wouldn't allow women to leave the home or whatever? Do you know what's happening with what happened during COVID with the shelters, women's shelters?
I think I'll take a stab at that. I don't know 100%. I think it was sort of an organization by organization decision. But I think I've definitely heard from members and sort of sector-wide calls that there is a concern that because of social isolation or physical isolation measures, people aren't as easily able to access help, go to their friends to get a phone, etc. Yeah.
But are you connected formally with the women's shelters or no?
We have we have some members that also provide shelter services in shelters.
Yeah, and my members are connected as partners on the ground, but it's not formalized across the province.
So if I could interject again, please. We've got just probably enough time for one question or so. And then, as I mentioned in the beginning, that we did want to dedicate a chair. If the three of you had something that you want to say, that we will cheer about tonight when we're thanking health workers. But if I could bring forth a question from Roy. And Roy says, I work in ER and see that bed allocation issues becomes a stronger reason to determine if they need to get admitted to inpatient mental health unit. Many minor aged patients do not get admitted, but discharged quite easily, especially in pandemic. How would you think about this?
Yes, right now we understand that the only kids who are getting admitted are if they're formed, if they're under a Form 1. No, I think that what we have to have is we have to make sure that we have the kinds of services that are a step down. I'm going to use that language. Specifically, very intensive services outside of hospitals to be able to serve these kids. You know, I certainly know this personally. As I said, my daughter ended up in an acute care hospital, but you know, at an acute care hospital, she gets stabilized. That's their job, is to stabilize her. Where the long-term treatment comes is out in the community, and we don't have enough intensive treatment centers for kids like that. And we have to expand services to make sure that we do. In fact, in our funding as to government, and I know it's the same for my colleagues as well, nurses are the ones that we really need in some of our clinical settings for those kids who are on multiple medications, and we need that kind of clinical care. So we need to expand those intensive non-hospital services dramatically across the province.
Great, thank you. There's been so much interest and comments in the chat box. If there's if there are a couple of outstanding questions, would we be able to email those to you for
Sure.
Of
follow-up?
course,
Okay.
yeah.
Okay, that would be great. So maybe, Doris, what I wanted to just do really quickly is to alert you to the slides. The recording of this will be posted on our COVID portal like every week, and as well as the slides. And there's some links to some updates here from last week. So a new report that we just put out, our AGM I mentioned earlier, the answers to questions last week.
And ladies, you are all invited to Thursday. You got the invitation today, 6 to 7 p.m. Come listen to the minister, all the ministers.
Thanks, Doris.
We didn't invite Tibolo, now that I think. We will.
Great. We have an upcoming webinar on traditional Indigenous approaches to mental health and well-being for healthcare providers. So that's coming up. And then next week, we have, our topic is Let's Talk About Racism. So that's the time that you're used to, 6:45, and we'll provide more details soon. So how about we prepare for our 7:30 cheer now, a little bit delayed, but nonetheless very, very important. And just wondering if there's anything that you would like to dedicate or say about this cheer tonight. And Olivia will enable more faces on the screen, and we'll get people to unmute themselves and get their noise makers. So how should we dedicate tonight's cheer?
I'm Morgan. Hi, Vane.
I think
Hello.
we will.
Put your camera on.
Everybody.
How about the cheer for mental health workers?
Nice. Thanks, Doris.
Okay.
Love it.
How about that?
Hold on just a
Thanks,
minute.
Doris.
Good.
Yeah.
Okay,
Our cheer is dedicated to mental health workers.
that is the
That's
case.
it.
So now we need to, I don't see enough participants here. Okay, we need to promote more people. Olivia, Alicia, take your mute. Otherwise we can't hear you or your daughter. Okay, so here we go. Grab or clap or do whatever you want.
Mental health
Cheers
workers.
to our mental health workers. Thank you for all the work you do every day, and especially during COVID-19. And yes, you deserve the extra pay.
Yeah.
Thank you, Doris. Thank you, RNAO.
Thank you.
Thank you, panel.
And thank you, panel. Yes, to Kim, to Adrienne, to Camille. Thank you so very much.
Well, thank
Thank
you
you,
for having
Doris.
us.
Thank you for
Thanks for
having
joining
us.
us tonight.
Thank you for all you're doing.
And we will connect to make a plan.
A huge thanks in the chat box right now.
Thank you so much, Camille, Kim, and Adrienne. This was wonderful. It was excellent.
Thank you.
Thank you
Thank
to
you.
all.
Thank you
It was
very
very,
much.
very helpful. Thank you.
Take
Good
care.
night,
Be
everybody.
well, everybody.
Thank you
Very
very much.
inspiring. Thank you very
Stay
much.
safe.
Bye.
Bye-bye.